Okay, so today we're going to be covering endocrinology, and you can see on this slide there's a lot that's screaming at you here. This is one slide that really tells quite a story about all the different endocrine organs that we have in the body and some of the key hormones that they either create or secrete. And what's interesting about it is you can look and you could see up here, well, we have the brain. So you're telling me we have parts of the brain that have endocrine function and, secrete uh, hormones. And then we see the lungs and we see the heart. Are you telling me that part of the respiratory system and part of the cardiac system actually has endocrine function? And then we can look at the stomach and the pancreas, and these are parts of the digestive tract. Are you telling me that parts of the digestive tract can actually create or have endocrine function? Absolutely. What about the urinary tract? So the kidneys are involved in endocrine? Yes. The adrenals, the reproductive tract, right? You look at all of this, and it's really not a separate system unto itself. It is really a combination of taking certain glands and certain organs from all the 11 systems, and they have endocrine function. So let's take a look and understand that when we talk about the control center of the human body, there are these two systems that work together. We have the neural system and the endocrine system. And these two are working synergistically together to control and coordinate all human function. The neural system is using these chemical messengers that are referred to as neurotransmitters, whereas the endocrine system is releasing these chemical messengers called hormones. And hormones and neurotransmitters are both going to bind to receptors. And the receptors on organs are called target cells, right? The target cell is where the actual hormone or neurotransmitter is aiming for to have some sort of influence on. And that influence is either going to be turning something on or turning something off. When we say turning something on, you'll usually hear the word excitatory. And when we turn it off, you'll hear the word inhibitory. So excitatory is usually stimulating something, activating something, exciting it, turning it on. And inhibitory is turning the volume down, right? Turning it down. I'll give you an example. In terms of neurotransmitters, we have an important neurotransmitter that, and I think we spoke about this in a prior lecture, we have a hormone that should be pretty high in the morning called glutamate, right? Your alarm clock goes off in the morning, glutamate is really bursting, and that's the opening of the flower in the morning when the sun comes up, right? You get up and out of bed, rise and shine, and you go into action. If you're a snooze button hitter when the alarm goes off, then you don't have enough glutamate. You're like, oh, just give me 5 more minutes, just let me sleep a little bit more. That means you're glutamate deficient. Glutamate is excitatory. That's an excitatory neurotransmitter in the brain. Now, throughout the day, as the day goes on, and then the sun starts to go down, and it's evening time, that glutamate neurotransmitter is going to be converted to another, assuming you have healthy B vitamins in your system. You need B vitamins to make these conversions. That glutamate gets converted to GABA. GABA, G-A-B-A, gamma aminobutyric acid, GABA, that is another neurotransmitter, but that's inhibitory. That's turning the volume down. That is not the accelerator like glutamate, that is the brake. That's slowing and toning you down so you can sleep at night. It slows the activity in the brain down so you don't have things running through your mind all night, right? So if you have no problem sleeping, then you have a good amount of GABA at night. If you have no problem getting up in the morning, you have a good amount of glutamate. But if you're the snooze button hitter because you just need a few more minutes of sleep in the morning, that may mean you're GABA dominant in the morning instead of glutamate. And at night, if you're having trouble going to sleep because you have everything going through your brain and you can't shut down the activity, then you're not GABA dominant at night, you're glutamate dominant at night. And these things can be affected, and these can be modulated with the right types of lifestyle changes and the right types of vitamins and minerals and nutraceuticals. And if those things don't work, then you have more invasive things called pharmaceuticals that can affect and have influence and to modulate. So neurotransmitters and hormones both can be stimulatory or inhibitory. The exocrine glands, right? You heard me say endocrine. Then there's exocrine, right? So exocrine are going to secrete their products into ducts, right? The exocrine glands we mentioned when we talked about epithelium, right? Exocrine glands are your sweat glands, which are sudiferous glands, your oil glands, which are sebaceous glands. They are mammary glands. We have mucus glands, digestive glands. These are all exocrine. Endocrine is going to secrete their byproducts directly into, not into ducts, but right into the bloodstream. Okay, they're carried through capillaries right to their target cell. And maybe the target cell is going to be on the pituitary gland or the thyroid gland, or the parathyroid gland, adrenal gland, and pineal or pineal. Certain organs and tissues that are not part of the endocrine system also secrete hormones because they contain secreting cells. We'll talk about a few of those, like the digestive tract has some secreting cells. Fat cells, adipose, adipocytes have secreting cells. Secreting cells can be found in the hypothalamus, which is in the brain, thymus, which is near the sternum, the pancreas, the ovaries, the testes, the kidney, stomach, liver, small intestine, skin, heart, fat cells, and even the placenta. That's right, the placenta is and has endocrine function. So let's take a look here so we understand where some of these main parts are. You'll hear me talk about some of their hormones they release. Sometimes you'll see, especially in the pituitary, there's a lot of abbreviations. I think it's important to know the abbreviations, but also know what they stand for, because in a lot of blood chemistry tests, when we run labs, sometimes it'll say TSH level. It may not say thyroid stimulating hormone, or it'll say GH levels. It won't say growth hormone levels, or LH instead of luteinizing hormone. So it's important to know what the abbreviations do stand for. And many of these parts function in harmony together. For example, the hypothalamus on the top left here, the pituitary, and the thyroid, in fact, these three in a row, these are directly connected with each other and in the same order that they're listed, meaning the hypothalamus is going to send a chemical messenger to the pituitary, and the pituitary will send a chemical messenger to the thyroid. And then the thyroid can send chemical messengers to other parts of the body. We call that the HPT axis, the HPT axis, the hypothalamic pituitary thyroid axis. But there's another axis called the HPA axis, which is the hypothalamus pituitary adrenal axis. meaning the hypothalamus will send a chemical message to the pituitary gland, and then the pituitary sends a message to the adrenals. So the HPT and HPA axis are extremely important and function together in harmony. So the hypothalamus is here in the brain, in a part of the brain that's called the diencephalon. The diencephalon. I do have a few lectures on the central neural system, and I have on the brain. So if you want to understand the different parts of the brain and some of their basic functions, I just did a lecture on this the other day. So if you go on my YouTube channel, Nutrition Chirodoc, you'll see one on the brain where I'm actually pointing to some of these key landmarks that I'm mentioning now, especially hypothalamus and pituitary. I point out on the models where they are, and we're going to discuss here what some of their functions are. So the hypothalamus is in part of the brain called the diencephalon. The hypothalamus produces ADH, which stands for anti-diuretic hormone. What does a diuretic do? A diuretic makes you urinate. It makes you pee, right? Coffee is a diuretic. Alcohol is a diuretic. So anti-diuretic is going to have the opposite effect. It's going to make you hold on to water instead of allowing you to urinate. Oxytocin, that is another hormone that is produced by the hypothalamus. Now, it just so happens that it produces them, and it's going to send them down to the posterior lobe of the pituitary where they're stored. They're stored, right? Oxytocin and ADH are stored in the posterior lobe of the pituitary. The other name for posterior lobe is called neurohypophysis. The other name for anterior lobe is called the adenohypophysis. So anterior lobe is adenohypophysis. Posterior lobe is called the neurohypophysis. The neurohypophysis can then release oxytocin and ADH, which then create many different functions. Oxytocin is what can act on a woman's uterus that will give her cramps during labor, or even cramps during that time of the month, right? When the menstrual cramps. Oxytocin makes the smooth muscle of the uterus contract. Oxytocin also has effect on the male reproductive tract. Okay, it will affect and create smooth muscle contraction of the vas deferens, or the vastus deferens, also known as the ductus deferens, which helps to release sperm during ejaculation. So oxytocin works on both male and female reproductive tract. Oxytocin is a bonding type of hormone as well between the baby and the mother. The baby and the mother have this strong effect towards oxytocin. Anti-diuretic hormone, ADH, is going to have the effect of allowing you to hold on to water. And basic principle, just for you to understand, that whenever you hold on to water, you're holding on to minerals. If you release water, you're going to be losing minerals. So water and minerals go hand in hand. And that is just a basic principle in nature, right? That's why it's called mineral water, right? That's how water comes in nature. When water is on a stream, it hits the stones and rocks, and it pulls calcium, and it pulls iron, and pulls all these minerals into the water. And that's the type of water that we should be putting in our body, is mineral water, and not distilled water, which is pure H2O, which is pretty much poison for the human body. You should never put in pure H2O that is distilled. That's dangerous. You know, we use distilled water to clean heavy machinery, right? To clean it. When you put distilled water in the human body, Remember what I said, water and minerals go hand in hand. That's natural. So if you put in pure water without the minerals, guess what it's looking for in the human body? Minerals. And it's going to pull out. It's going to pull out minerals from your bones. It's going to pull out minerals from your muscle. It'll pull out minerals from your organs, right? And that's why it's very, very problematic. So the water that we should be consuming, when you drink water, it should have minerals in it. This water here that I'm drinking, actually, when I look at the ingredients, it actually has the mineral content in it, which is really, really nice. Okay, so anti-diuretic is going to allow you to hold on to water and hold on to minerals when you have something that's going to stimulate diuresis, which is the loss of water. You're going to be losing minerals. That's one of the problems with diuretics, right? When someone has high blood pressure and they have edema or swelling around their ankles and they're retaining water, most physicians will put them on a diuretic like Lasix or something. And the problem with that is that when they lose water through excessive urination, guess what they're losing with it? Minerals. And some minerals are really important because they have electrolyte function. If you lose electrolytes, you start to lose the ability of how your neural system functions and how the cardiovascular system functions. And there are some people that actually die instantaneously when they're on these diuretics from what's called ventricular ectopy, where the heart just stops because they lose potassium and they lose magnesium. And potassium is really important as an electrolyte. You don't want to lose potassium. You don't want your potassium levels to get too high, and you don't want them to get too low. It becomes problematic. So this is why they came out with these diuretics that are referred to as potassium-sparing diuretics, because they want the blood pressure to drop without losing potassium. They know if you lose potassium, other minerals are going to follow it, and then we have major dysfunction in the human body. So the potassium sparing holds on to potassium, then you're going to hold on to magnesium, you're going to hold on to some other minerals, but what they've discovered is that they're not as effective as a diuretic. And some of those, I think there's a big one that's called Spirolactone, is a diuretic that's potassium sparing, and they use it off-label for women, especially that have excessive hair loss. They've discovered that one of the adverse reactions to that drug is women were claiming they were growing hair and their hair was thicker. So most endocrinologists, when women come to see them and they say, I'm looking in the shower and I'm finding excessive amounts of hair in the shower, they'll give these women spirolactone. In about 4 or 5 months, they're claiming their hair is much thicker than it's been, and growing hair in wanted places, not unwanted places. Okay, so we did the hypothalamus. We talked a little bit about the posterior lobe. The anterior lobe has a lot of different hormones it releases. One of them is Adrenocorticotropic hormone. When you look at that Adrenocorticotropic hormone, when we go to the adrenal gland, right, the first A is for adreno, which is the adrenal gland. The adrenal gland has an outer part called the cortex and an inner part called the medulla. And each of those parts of the adrenal gland themselves are responsible for secreting different hormones. And on the lab portion within Connect, they often ask you microscopically those different layers and what they are responsible for releasing. I've seen that pop up many times. So Adrenocorticotropic hormone, adreno tells us the adrenal gland, cortico tells us the cortex of it, and the cortex of the adrenal gland is the outer part. The medulla is the inner part. If you look here, the adrenal gland, the adrenal medulla, which is the inside, releases epinephrine and norepinephrine, aka adrenaline and noradrenaline, whereas the adrenal cortex, the outer part, secretes cortisol, cortisone, corticosterone, aldosterone, which is a mineral corticoid, and some sex hormones, androgens. Okay, so that's adrenocorticotropic hormone. Then you have TSH, thyroid stimulating hormone. Then you have growth hormone, prolactin releasing hormone. Right? So let's go back. Thyroid stimulating hormone is going to have impact on the thyroid. Growth hormone is going to affect your cartilage, your muscles, your tendons to help them regenerate, repair, and grow. Growth hormone has its impact about 40 to 50 minutes after you sleep. Right? That's why taking naps are really important for growth and rejuvenation. Not just of children, but even adults. Growth hormone is very, very important. Most professional athletes will take a nap in the daytime purely for that extra burst of growth hormone. Problems with growth hormone, especially if you have a sweet tooth at night and you have like cereal before bed, a few cookies before bed, some sort of sugar, refined carbohydrate before bedtime, it actually blocks the receptor sites. So although growth hormone is being released, it's not going to have its impact because the receptor sites are being blocked. Prolactin releasing hormone, when you look at prolactin, it's pro-lactation, right, for milk production. FSH, follicular or follicle stimulating hormone. That's important for sperm production and egg production, male and female. Luteinizing hormone, LH, that's an important one. That's where they have these tests for women when they're trying to get pregnant for a planned pregnancy. This is what they're constantly checking with some of these tests with the litmus paper, and they dip it in the urine, and when it's, really high, these are the commercials where they call their husband and say, come on home, hurry up. When LH levels rise, it means the woman is ovulating. Ovulation means that the ovary, which is down here, if you look in the picture, when the ovary secretes or releases the egg, it pushes out, and then here, this is the fallopian tube. At the end of the fallopian tube are these finger-like extensions that you can see here. They're called fimbriae. And these fimbriae have a vacuum effect. So if this happens to be if my hand is the ovary, and inside the ovary is an egg, now when LH spikes, it pushes out the egg, and then the fimbriae find it, and it scoops it up. And now this egg is going to move along the fallopian tube. And those cilia are beating rhythmically to propel it and move it. And then the sperm were ejaculated through right into the vaginal area. Now it's moving into the uterus, finds its way into the fallopian tube or the uterine tube, and that's where sperm and egg meet, or where they should meet. And when sperm and egg meet in the fallopian tubes or the uterine tubes, that's where fertilization takes place. So fertilization takes place in the fallopian tube, and then the beating cilia move that fertilized egg back into the uterus. And in the uterus, in the endometrium, that's where implantation should take place. If implantation takes place anywhere else, that's called an ectopic pregnancy. An ectopic. That's where implantation takes place anywhere other than where it should take place, which is in the uterus. Okay, so LH levels are going to spike. That means that is the time of ovulation where the egg is propelled and pushed out of the ovary into the fallopian tubes. And MSH is melanocyte stimulating hormone. Thyroid produces T4 and T3 and calcitonin. T4 is when tyrosine and 4 iodines come together. So the 4 is for the 4 iodines, and the T is for tyrosine, which is an amino acid. When you have 3 iodines attached to a tyrosine, we call that triiodo, right? Iodo, iodine, triiodothyronine. That's T3. So when TSH, thyroid stimulating hormone, hits the thyroid gland pushes out T4. And T4 gets converted into T3. And you know where the majority of that conversion takes place? It takes place in the liver. That conversion takes place in the liver, but we need selenium. It is selenium dependent. We need that mineral called selenium. The TSH, thyroid stimulating hormone, hits the thyroid gland on its target cell, right, on its receptor, and it's fat soluble. So you need to have healthy fat in your diet so the fat can be broken down and put on the receptors so that the thyroid stimulating hormone can hit the thyroid to push out T4. T4 gets converted to T3 in the liver. The thyroid can push out a little bit of T3, but not as much as the liver can. Now, what's this calcitonin? Calcitonin, most people don't know what calcitonin does, but you see the word calc in there, so we think it has something to do with calcium, right? And it does. Calcitonin is a hormone that the thyroid releases when your calcium levels in your blood are too high. And then its job is to take that calcium and drive it into the bone. Or it'll help you excrete it through urination. And calcitonin shuts down your ability of your digestive tract to absorb more calcium. So calcitonin has the ability of helping us reduce calcium levels if it gets too high 3 ways. Push it into the bone, push it out through the urine, and stop absorbing calcium from the digestive tract. Adrenal glands. We have the adrenal medulla and the adrenal cortex. I'll show you a picture of that shortly. The pancreas produces 2 main hormones. The beta cells produce insulin, whereas the alpha cells produce glucagon. Insulin is designed to lower blood sugar, whereas glucagon is designed to raise blood sugar. In the pineal gland, up here, just above the cerebellum, that produces melatonin that helps you sleep at night. It's part of your biological clock. Melatonin helps you tone down at night to sleep. Melatonin has major impact right now, very helpful during COVID-19. There's lots of research out there showing beneficial effects of melatonin. Melatonin is very helpful, lots of research today in regarding IBS and irritable bowel syndrome, and melatonin having major impact on helping with the symptoms of IBS. The parathyroid is posterior to the thyroid, so you can't really see it unless you're looking at it on the lateral lobes, but on the posterior side of it. It produces PTH, which is parathyroid hormone, which works in the exact opposite way of calcitonin. So calcitonin and parathyroid hormone work synergistically together, but in opposite ways to modulate calcium. So calcitonin was trying to decrease the amount of calcium in your blood. Parathyroid hormone is trying to increase the amount of calcium in your blood. Okay? The heart itself tries to regulate blood pressure by releasing atrial natriuretic peptide. When you look at the word natriuretic, it looks like diuretic, but the first two letters of natriuretic or natriuretic is Na. And on the periodic charts, or the periodic charts of the elements, what is Na, right? Na is sodium. So the heart has the ability of trying to release ANP to get rid of sodium. So you can pee out sodium. And if you're peeing out sodium, you're losing water. If you lose salt and you lose water, you can lower your blood pressure. If you hold on to salt and hold on to water, your blood pressure goes up. And that's what this hormone does, aldosterone. Aldosterone and ANP, they're antagonistic to one another. Aldosterone says, hey, let's hold on to salt, sodium. Let's hold on to water. Let's kick out potassium. And ANP is saying, let's kick out sodium. Let's kick out water. Let's hold on to potassium. Right? Sodium and potassium always move in opposite directions. If one's being held on to, the other one's being excreted. When you look at the cell, we call that the sodium-potassium pump. Okay, the thymus undergoes atrophy during adulthood. When you're an infant or child, you're crawling on the floor. You're like a human vacuum, putting everything in your mouth, sucking up everything, and your immune system just really goes through incredible amounts of development. And when we become an adult, the thymus starts to shrink. It atrophies a little bit. But the thymus does secrete thymosins, which is involved in producing T cells. Your fat cells or adipose release leptin. Your digestive tract secretes a lot of different hormones. We'll talk about an important one that the intestines produces, especially the duodenum of the intestine, which is right here, right there. So here's the stomach. Here's the duodenum. The duodenum releases something called CCK, cholecystokinin. And I'll go over what cholecystokinin does in a little bit. Kidneys secrete EPO, erythropoietin, and calcitriol. Calcitriol is vitamin D. So you need healthy kidneys to produce vitamin D. You need good sunlight, number one. You need healthy skin, number two. You need a healthy liver, number three. You need healthy kidneys, number four. And you need cholesterol, number five. So you need a lot of things for your body to produce vitamin D. You need good UV rays from the sun. You need subcutaneous cholesterol. You need cholesterol on the skin. You need healthy liver and healthy kidneys to produce vitamin D. The kidneys also produce erythropoietin. Poietin means to produce. Erythro refers to erythrocytes, which is red blood cell. Red blood cell producing. That's what EPO does, meaning blood will go through the kidneys to be filtered. And the kidneys are the perfect organ to measure oxygen levels. If your oxygen levels dip, your kidneys are going to go, hey, we don't have enough oxygen. Let's push out some erythropoietin. Okay, erythropoietin, you're going to go to the bone marrow. You're going to go deep in the bone, and you're going to tell the bones to push out a lot more red blood cells. So if we have more red blood cells, then we have more hemoglobin, and oxygen binds the hemoglobin, and oxygen levels can go up. Okay? Then we have the gonads, testes, and the ovaries. So the testes are going to produce some androgens like testosterone, and the ovaries are going to produce estrogen and progesterone. So you need estrogen in order to get pregnant, and then you need progesterone to maintain a pregnancy. If progesterone levels dip, most likely there will be a miscarry, and that's one of the things that an endocrinologist will look at to determine the success of how a woman can maintain a pregnancy because the unfortunate reality is about 1/4 of women will miscarry in the first trimester. 1/4 of women. When women, I'm going to give you a little clinical gem here, which you probably never have heard of, but if I was a betting man, which I'm not, I would bet that what I'm about to say relates to at least one student in our class, either directly or through a family member or friend. There's always that one person that we know of, the one female who has miscarry after miscarry after miscarry, and they just have trouble holding. I would strongly recommend getting tested for something called MTHFR. MTHFR. There are these SNPs. MTHFR stands for methyl tetrahydrofolate reductase, which is an enzyme that we all should have, and it enables us to properly use folic acid. And if there is a genetic SNP that that doesn't allow a particular individual to have enough of that enzyme, then folic acid levels dip. And we know that during pregnancy, what's the first thing most doctors want women on is folic acid. But what's happened is not folic acid in that form. Many women that take folic acid have babies that have cleft palate or hair lip or meningomyloceles, where the nervous system, it grows outside of the spine. These are MTHFR issues. So please get tested for that. There's a lot of other issues that relate to MTHFR. We see migraine headaches in adults. We see depression, bipolar, ADD, autism. We see quite a bit, including miscarriages, neurotransmitter imbalances, people that have difficulty losing weight. These tend to be all associated with MTHFR. So you can get that tested. There are these two SNPs that you can check. They are called the C677T and the A1298C. Those are the two chromosomes, the C677T and the A1298C, if you wanted to write those down. Okay. So when we look at hormones, you'll see that there are different chemical classifications. We have some that are called lipid soluble, right? So steroid hormones like aldosterone, cortisol, calcitriol, some of these sex hormones like testosterone, thyroid hormones, T3, T4. Remember I said they're fat soluble. You need good, healthy fat on these receptors for these things to work. So people that are on no-fat diet or low-fat diet, bad, 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 right? It's the balance. Fat is good for you. You want good, healthy fat in your diet. That doesn't mean, French fries and fried things or consuming trans fatty acids. Definitely not. But you do need healthy fat in your system. Certain gases like nitric oxide that allow your blood vessels to dilate, so blood pressure goes down. You look at water-soluble, certain amines like melatonin, histamine, serotonin. You've heard of these. Like serotonin is a neurotransmitter as well. Glutamine, cysteine, glycine, tyrosine. These are from proteins. These are peptides, right? These amino acids. So we need them to produce oxytocin, ADH, growth hormone, thyroid stimulating hormone, right? All of these, pituitary, whether it's anterior or posterior, right? These two are posterior pituitary. These are all anterior pituitary hormones. Then we have hormones from the pancreas. You have insulin, glucagon, pancreatic polypeptides. You have thyroid hormone and parathyroid hormones like PTH. calcitonin. Here's the one from the small intestine, that cholecystokinin. Remember how I said you need fat in your diet for the thyroid to work? Well, when fat is in the stomach, your stomach knows there's fat in there. It's going to be emptied. It's emptied into the small intestine called the duodenum. The duodenum releases cholecystokinin, CCK. Cholecystokinin goes to the gallbladder. The gallbladder contracts as a result of CCK. So CCK is a hormone that makes the gallbladder contract, and when it contracts, it pushes out bile. What is bile? Bile breaks down fat. It emulsifies fat. That word emulsification means to break fat down. That bile is first produced in the liver. The liver and the gallbladder are like close cousins. They live right next to each other. So the liver makes bile, but it stores it in the gallbladder. The duodenum releases CCK, goes to the gallbladder, makes it contract, and now you have bile in circulation that can break down that fat and put the fat on those receptors where they belong. Okay? Yeah, the kidneys produce erythropoietin, the fat cells produce leptin. These eicosanoids are really, really important for those that are getting into healthcare and getting into nursing and dealing with different pain syndromes. Eicosanoids are responsible for the different hormones that fall under eicosanoids are these two biggies called prostaglandins and leukotrienes, and these are involved in inflammation. Prostaglandins, this is what's going to give you a fever. Prostaglandins are going to produce mucus in your stomach so that you don't get ulcers. Prostaglandins make the woman's uterus contract during menstrual cramps. So now you understand why if you take an Aleve or Advil or aspirin, your fever can go down because it's a prostaglandin blocker. Not only does your fever go down, menstrual cramps go away because prostaglandins produce cramping. But prostaglandins also produce mucus that lines the stomach so you don't get an ulcer, right? The stomach has a lot of acid in it. You need to have mucus to protect so that the acid doesn't erode the stomach away. Now you take aspirin, you block the prostaglandins, you can't produce mucus, and your hydrochloric acid in the stomach is going to give you an ulcer. Okay, this is just showing that there's a difference between the mechanism of hormone action between lipid-soluble hormones and water-soluble hormones, how you can see the lipid-soluble hormones bind to receptors in the target cell, and then the water-soluble binds to the receptors on the exterior surface of the target cell. So the mechanism of action is just slightly different. What's going to affect the hormone production and when it knows not to be produced or released anymore are these feedback loops that we learned early on. So most hormone regulation is achieved by a negative feedback loop. There's very, very few that work on a positive feedback loop. Negative feedback loops, remember, work this way. You're running, your heart beats faster, you're breathing quicker, and when you're done, your body has a way of bringing your heart rate back and your breathing rate back. Negative feedback loop. You eat a meal, you drink a soda that has lots of sugar, your blood sugar level goes up, but then insulin has a way of driving it down. That's a negative feedback loop. So most hormones work that way. But positive feedback loop is now woman is pregnant, oxytocin is making the uterus contract, the woman has cramps. You'd think that the body has a way of reducing that pain, but any woman that's been in labor knows that the cramps get worse and worse and worse, and the spasms get worse and worse because the body keeps pushing out oxytocin. And the only time the cramps and the oxytocin stops is when the baby actually is delivered. okay? Then it becomes a negative feedback loop. But during the time of the actual entire laboring process, it's a positive feedback loop. So here's that connection between the hypothalamus and the pituitary. The hypothalamus and the pituitary are intimately connected, and they're connected through this infundibulum, which is like a stalk. And then there's the neurohypophysis and the adenohypophysis, or posterior pituitary and anterior pituitary. You could see back here is posterior pituitary. Here is the anterior pituitary. We could see that there's this capillary system in which when the gland produces hormones, it's going to go into circulation and then eventually affect different parts of the body. So you may have growth hormone that's going to make your bones and skeletal muscle become thicker and stronger, or you'll have thyroid stimulating hormone go into the thyroid gland to push out thyroxine or T4, or you'll have adrenocorticotropic hormone. The outside of the adrenal gland is the cortex, so adrenocorticotropic hormone goes here. Then you have prolactin going to the breasts for milk production. You have follicular stimulating hormone and luteinizing hormone, both affecting the reproductive organs, the ovaries and the testes. Here's another great slide. You see on the top right, it gives us the abbreviations and then the actual names of those hormones. We see that the hypothalamus does have connections to the pituitary. It will send hormones to the pituitary that will either be stimulatory hormones or inhibitory. So when the pituitary is then stimulated, right, you got the anterior lobe hormones here, and you got the posterior lobe hormones here. So adrenocorticotropic hormone is going to go to the adrenal cortex out here. The adrenal medulla is on the inside. The adrenal medulla produces what's called catecholamines. Catecholamines are epinephrine and norepinephrine. These are going to be directly connected to your sympathetic nervous system. Your sympathetics are part of the autonomic neural system. Your sympathetics is known as your fight or flight response. Like you're being chased by a tiger, your heart's going to race, your breathing is going to speed up so you take in more oxygen. Your pupils are going to dilate so you can see better at night. That's all fight or flight. Your parasympathetic is more rest and digest, or feed and breed. It's the more calming system. Everything's like accelerator and brake. So sympathetic is more accelerator, parasympathetic is more brakes. The only time that flip-flops is for digestion. Your parasympathetics makes your digestive tract work faster, and the sympathetics would make it work slower. So that's an instance where they actually are opposite. And this you kind of know to be true because, you know, your mom or grandma would say, after you eat, don't go outside running and playing, because when you're eating, that's a parasympathetic thing, right? You don't want to be running around playing, which is sympathetic, fight or flight, when you're trying to digest your meal. So the adrenal cortex, that's going to produce, the outer part's going to produce cortisol and cortisone. Those are called glucocorticoids. The glucocorticoids are produced in the cortex of the adrenal gland. And what do you think glucocorticoids are going to do? They're going to increase your glucose level. So if you're in a fasting state and you haven't eaten anything, your body has an innate mechanism to try and make sugar so you have fuel. Okay? That's cortisol. That's going to help you produce and increase cholesterol and increase sugar. And that's why stress kills, right? Your adrenal gland is kind of like your anti-stress gland. If you're being chased by a tiger and cortisol is being produced, which is a glucocorticoid, it's going to increase your sugar for fuel and energy. It's going to increase cholesterol, thicken up your blood a little bit. So if you get clawed by that tiger, you won't bleed to death. So good, interesting innate mechanisms. The adrenal medulla, that's your adrenaline, noradrenaline, that's your sympathetics, fight or flight response. The anterior pituitary produces thyroid stimulating hormone to go to the thyroid gland that produces T4. We said T4 gets converted to T3 in the liver. We have growth hormone. Growth hormone is going to get processed there in the liver, but it will eventually affect every cell of the body to help it rejuvenate and grow and repair. Prolactin releasing hormone goes to the mammary glands for milk production. We both have follicular stimulating hormone and luteinizing hormone that will affect the testes and the ovaries. When the testes are functioning well, they'll produce testosterone or inhibin, and the ovaries can produce estrogen or progesterone or inhibin. The melanocyte stimulating hormone, they're not too certain as to what the melanocyte significance is in healthy adults. They're not too sure. They're still researching this one. But oxytocin, we said, will make the female smooth muscle constrict and contract, and it makes the vas deferens or the ductus deferens and the prostate gland constrict and contract during ejaculation. And antidiuretic hormone is going to allow the body to hold on to water and minerals. So you should be familiar with those hormones and the abbreviations. We've gone over their functions a few different times, but AMP, it's all structure and function. Let's just see if there's anything else here that I want to touch upon. Okay, we covered these already. And then again, antidiuretic hormone, the ADH decreases urine output. Remember, if you're peeing less, you're also going to push out less minerals. An increase in blood volume causes a decrease in antidiuretic secretion, and a decrease in blood volume causes an increase in antidiuretic hormone secretion. So if you have decreased blood volume, if you have a decrease in blood volume, what's going to happen to your blood pressure? It's going to go down. And if blood pressure goes down, your body's going to push out and increase antidiuretic hormone so that you're not losing more liquid or fluid and minerals and salt and sodium chloride. It wants you to hold on to that, so blood pressure goes back up. Okay, so there's the picture of the thyroid gland. You could see it has two lobes, and in the middle, there's an isthmus that connects the two. Same thing here, we have a right lateral lobe and a left lateral lobe, and the isthmus that connects the two. The thyroid gland has these follicular cells. The follicular cells are stimulated by thyroid stimulating hormone to produce T4 and T3. The parafollicular cells, which are around that, I've seen this show up as well on Connect on the lab, microscopically or histologically, where you're looking at a follicle and you're looking at the thyroid microscopically, and you have to identify follicular cells and parafollicular cells. So make sure you are comfortable and you can do that. But the parafollicular cells produce calcitonin. Remember, calcitonin modulates calcium balance. It's going to take any extra calcium that's circulating in blood and drive it in bone, allow you to pee it out, and it's going to tell your body to say, hey, let's stop producing vitamin D, because we know vitamin D is going to help you absorb more calcium, which is not what the body wants. So you have to be familiar with this down here at the bottom, where you're looking at thyroid follicles. So these over here are the parafollicular cells known as C cells, right? And then here are the follicular cells, which are surrounding this. This is the actual thyroid follicle. And here in the middle is the thyroglobulin, or also known as the colloid. The thyroid hormone is designed to increase your BMR, your basal metabolic rate. It's going to maintain your body temperature. Thyroid hormone is involved in stimulating protein synthesis. Thyroid hormone can increase the use of glucose and fat or fatty acids and triglycerides for energy production, which is ATP production. It's going to upregulate beta receptors that attach to the catecholamines. Your catecholamines are epinephrine and norepinephrine, or adrenaline and noradrenaline, which are released by the adrenal medulla. So what I was saying before was that tyrosine and 4-iodines, that is T4 or thyroxine, and then T4 gets converted into T3, it's going to happen in the liver, right? Because it uses this enzyme. Anything that ends in ACE is an enzyme. So D2 thyroxine deiodinase, that's a liver enzyme. It takes place in the liver, but it requires selenium to make this conversion from T4 to T3, and you need bile. Remember, bile is going to break down fat, and that bile is produced in the liver. So the liver is really important for thyroid function. One of the interesting things is that thyroid releasing hormone is secreted by the hypothalamus, okay? And thyroid releasing hormone that's secreted by the hypothalamus is going to go to the pituitary and tell the pituitary to release thyroid stimulating hormone, right? So TRH stimulates TSH. But what is it that's telling the thyroid releasing hormone to be released? It's histamine. It's histamine. So histamine binds to the hypothalamus and says, hey, push out TSH and go to the thyroid and tell the thyroid to push out T4. Histamine. Now, histamine comes in a few different flavors, H1 and H2. So H1 histamine receptor is in the brain, H2 is in the gut, right? Like H2 blockers in the stomach, H2 blockers and proton pump inhibitors are going to decrease the amount of, those are known as antacids, right? So an H2 histamine receptor is for the histamine production for the stomach. So you don't produce an amount of hydrochloric acid. The H1 is up in the brain. And you know what down regulates that or blocks it? Antihistamines. People that have allergies that use, let's say, Benadryl and Claritin, what I've been seeing in practice is that people who are taking for long term these anti-allergy meds that are these antihistamines, they end up developing the subclinical hypoactive thyroids. So really important that when someone has a hypoactive thyroid, good to do a good case history, look at any of the medications and see if there's any history of antihistamines, like allergies, seasonal allergies. And then the other thing is also gallbladder history. Because remember, the gallbladder produces bile. You need bile on the receptors for the thyroid to work. So if people have their gallbladders removed, we're also seeing a higher correlation between people that have gallstone attacks, that have their gallbladders removed, and then a few years later end up with a hypoactive thyroid. Goiters are when the thyroid is very large. That's called a goiter. It really is kind of like a generalized term. It's not really specific, but it just means that the goiter is enlarged. And some of the common causes of that are Graves' disease and Hashimoto's, an iodine deficiency, and some of the symptoms are going to be tachycardia, that fast heart rate. There'll be weight loss, exophthalmos, especially when it's enlarged and the thyroid gland is working overtime, right? It's hyperactive. So when it's hyperactive, the heart races, your metabolism speeds up, so there's weight loss. The eyes bulge out. They call it exophthalmos. There's temperature sensitivities. You're hot, you're cold, you're hot, you're cold, sensitivity to heat. You're tired and fatigued all the time. So just because someone has fatigue doesn't always mean that they're anemic or they have iron deficiency anemia or B12 anemia. It's important to look at thyroid function. Also look at their bowel habits. So Graves' disease is hyperactive thyroidism. It is an autoimmune disorder known as thyrotoxicosis, and they get a goiter. They get this pretibial myxedema, which is like swelling around the ankles. They also get puffiness around the eyes and eyes bulging out. So here's the myxedema. It looks like these bags, these heavy, saggy bags under the eyes. That is myxedema. We see this with a hypoactive thyroid. And the exophthalmos is this protruding where you can see the white of the eye all the way around the top and the bottom of the eye. This is exophthalmos with a hyperactive thyroid. Now, Hashimoto's, this is believed to be the most common cause of hyperthyroidism, more common in females than in males, but it's autoimmune in nature. And it's when your body is producing these antibodies that resemble thyroid stimulating hormone. So it's not thyroid stimulating hormone, but your body is producing something that looks and mimics it. So it's constantly stimulating the thyroid to push out T4. It's like an on switch, and eventually it gets burned out. So what starts off as this hyperactive thyroid eventually burns out and becomes a hypoactive thyroid. That's Hashimoto's. We're seeing a very, very strong connection between Hashimoto's and people who consume lots of gluten in their diet. So really important to look at a comprehensive thyroid panel, and important to look at not just TSH levels and T3 and T4 levels and anti-TPO levels, but there's something called reverse T3 that you want to look at. So reverse T3 is kind of like T3. Let me give you an example of how that would work. So let's say here is T3. So I have T3, which is this pen, and then reverse T3 is a mirror image of it. It's upside down. So T3 wants to find this receptor, bind to it, and then it allows things to function. Your metabolism may speed up. Okay? Now that's T3. Now here's reverse T3, which is reverse. It's opposite. When your body is under stress, or you have allergies or toxins, or you're putting something in your body that's stressing you out that doesn't belong there, you produce not lots of T3, but reverse T3. And when reverse T3 outnumbers T3, T3 sits in the same receptor that T3 was trying to sit in, but it does nothing. Reverse T3 just sits in that receptor. It's functionless. It does nothing but occupy that receptor, which means that T3 has no place to go. So you develop these hypoactive thyroid symptoms with normal TSH, normal T3, and normal T4. And a lot of endocrinologists are like, well, you may have the symptoms of it, but your hormone levels are good. Many of them just don't check reverse T3. So it's really important to be comprehensive on a lot of that blood work. If it sounds like you, get your reverse T3 levels checked, okay? Goitrogens, these are substances that are found in foods that suppress thyroid function. They suppress thyroid function by interfering with the uptake of iodine. You have to be careful with the brassica family, like cabbage and broccoli and things of that nature. Soybeans, peanuts, strawberries, peaches, pine nuts, radishes, those are all goitrogenic foods. Okay, we spoke about the thyroid follicle and the follicular cells and parafollicular cells. So please just make sure you review that. The parathyroid glands are on the posterior part, right? This is the thyroid. And we're looking at this person from the posterior. So what we're seeing are the lateral lobes. And on the superior part and the inferior part of both right and left lobes is where the parathyroid glands are. And the parathyroid glands have these chief cells that are known as principal cells. They're going to produce PTH. And parathyroid hormone works in the opposite way of calcitonin. So here we see calcitonin on this side, and we see PTH on this side, right? So what is calcitonin trying to do? Calcitonin is saying, hey, calcium levels in the blood are very high, and we need to try and reduce it. Okay, so calcitonin is going to be released, and that's going to inhibit osteoclast, which means bone is not going to break down, which is going to decrease the level of calcium in your blood. It's going to stimulate your osteoblasts so you can put calcium in your bone. It's going to stimulate urinary output. It's going to stimulate urinary output, so you lose urine and you lose calcium. And it just turns off vitamin D, so you're not absorbing anymore. Now, parathyroid hormone works the opposite way, where it's going to increase blood calcium level. It's going to stimulate osteoclast, so you're breaking down bone and releasing calcium into the blood. It's going to turn off urination, so you're not losing calcium. It's going to turn on vitamin D, so you can absorb calcium from your diet. So calcitonin and PTH work in opposite ways. You can see here that here are the parathyroid glands on the back of the thyroid. PTH is designed to increase the amount of calcium in your blood. So it's going to stimulate osteoclast to break down bone, to bring calcium into the blood. It's going to increase calcium absorption from the digestive tract by activating vitamin D to absorb more calcium, and it's going to increase calcium reabsorption. Now let's take a look at the adrenal glands. So here's the kidney, and above the kidney is the suprarenal gland, or adrenal, right? Renal means kidney, like adduct, to bring something towards it. So here's the adrenal gland. The adrenal gland has an outer part called the cortex and the inner part called the medulla. You're going to see this word cortex a lot in anatomy. You're going to see it around the kidneys. You're going to see it around the adrenal glands. You're even going to see it around the brain. The outer part of the brain, which is gray matter, is called cerebral cortex. The word cortex literally means bark, like the bark of a tree, the outer part of an oak tree, let's say, that's bark. So what you want to know, you want to make sure, I've seen this pop up quite a bit on the lab, when you look at the adrenal cortex, you'll see microscopically, here's the adrenal cortex, you see these zona regions, zona glomerulosa, zona fasciculata, zona reticularis. So these three zones are part of the cortex. As you move into the medulla, down here at the bottom, that's the adrenal medulla, which is where the chromaffin cells are, and that's going to produce your catecholamines, which is adrenaline and noradrenaline, aka epinephrine and norepinephrine. When you look at the cortex, the adrenal cortex, the outer part, or the more superficial part, is going to secrete your mineral corticoid. Mineral corticoid is aldosterone. The mineral that it's involved with, it's going to, when you see that hormone, aldosterone, it's going to say, hey, I want to hold on to sodium. That's the mineral. I'm going to hold on to sodium. We're going to push out potassium. Hey, when we hold on to sodium, we're going to retain water. And that's what aldosterone does. Deeper to that is the fasciculata. That's going to secrete glucocorticoids. You got mineral corticoids and glucocorticoids. The glucocorticoids are cortisone, cortisol, corticosterone, big pity, little pity, right? So you got the cortisol, cortisone, corticosterone, they all sound alike. Those are your glucocorticoids. The zona reticularis, which is the deepest part, just before you hit the adrenal medulla, that's going to secrete your androgens, right? The sex hormone, like testosterone. So be familiar with those. So your mineral corticoid is going to regulate mineral homeostasis. You got to think aldosterone with that. Your zona fasciculata is going to secrete the glucocorticoids. I'm thinking cortisol, cortisone, corticosterone. The biggie is cortisol. And then you have the zona reticularis that's going to secrete your androgen. Androgens are the masculinizing sex hormone. Aldosterone, we said, is going to help regulate sodium and potassium balance. You're going to hold on to sodium, push out potassium. I'm going to show you the RAS system, which is the renin, angiotensin, aldosterone system. It's really an important system in terms of regulating blood pressure. When you look at the word renin, I see the word renal, so we're thinking kidney. When you see angio, like an angiogram or angioplasty, I'm thinking blood vessels. When I see the word tensin, it looks like tension. So angiotensin looks like tension within blood vessels. And renin and aldosterone are going to affect that. So let's take a look. We call it the RAS system. Renin, angiotensin, aldosterone system, RAS. It just doesn't have the S here. So we have something that's decreasing your blood pressure. Maybe it's dehydration, not drinking enough water. Maybe there's a salt imbalance, a sodium deficiency, or you're losing blood, right? Any combination of these things is going to decrease your blood volume. If you have decreased blood volume, you're going to have decreased blood pressure. All the blood is going into the kidneys. Kidneys are filtering out the blood. Now your kidneys are saying, hey, you know what? There's not enough blood here. There's not enough pressure. I'm going to secrete an enzyme, a hormone called renin. At the exact same time, your liver is releasing something called angiotensinogen. Now, anything that ends in ogen, you see this, O-G-E-N, anything that ends in ogen simply means it's inactive. So angiotensinogen is a hormone, but it's just inactive. All right, well, how do we activate it? Well, good question. We activate it by the kidneys releasing renin. So renin bumps into angiotensinogen, and all it does is knock off the ogen. And it becomes angiotensin 1. Now, if there's an angiotensin 1, it leads us to believe there's going to be an angiotensin 2. Well, how does angiotensin 1 become angiotensin 2? Great question. That's where the lungs come into play. Your lungs produce this enzyme called ACE, and ACE stands for angiotensin converting enzyme. You've heard of certain drugs on the market that are called ACE inhibitors. ACE inhibitors are blocking this enzyme that the lungs produce to convert angiotensin 1 into angiotensin 2. Well, why would we want to block ACE to block converting angiotensin 1 into angiotensin 2? Another good question you ask. If you don't have if you have, let's start with that. With angiotensin 2, blood pressure is going to go up. So if you block ACE and you don't release angiotensin II, blood pressure stays low. Okay, but remember here we started with low blood pressure. The end result is we want to try and increase blood pressure. So we want angiotensin I converting to angiotensin II. The lungs produce ACE, which is going to make that conversion. This needs zinc, by the way. This is zinc dependent. Interesting, right? Lungs and zinc. We hear a lot of connections between people who are zinc deficient and COVID, right? One of the treatments that are being used for COVID is high amounts of zinc, not only for immune system function, but also for lung function. Zinc. So ACE is zinc dependent. Now, the body can produce angiotensin II. What does angiotensin II do? Look what it does. It constricts the arteries. So if your arteries constrict, blood pressure goes up. What else does it do? It goes to the adrenal gland. It's going to go to the adrenal cortex. Well, what does the cortex do? Oh, you got that mineral corticoid called aldosterone. What does aldosterone do? It increases sodium and water absorption, and it's going to secrete potassium. What is that going to do? Increase blood volume. When you increase blood volume, you increase blood pressure. When you vasoconstrict, you increase blood pressure. Amazing, right? That's the beauty of the RAS system. The glucocorticoids, especially cortisol, that's the most commonly produced glucocorticoid. It's going to break down protein. When you're under stress, your body pushes out cortisol, you break down protein. Cortisol increases fat deposition, fat depositing around your abdominal area. So you'll get the big belly and you'll get the skinny legs. Okay, that's what cortisol does over long periods of time. It's involved with glucose formation, fat lipolysis, which is breaking down fat. It helps you resist stress. It's involved with inflammation and your immune response. This is why when you're under stress and your body is pushing out cortisol, people get sick all the time. A major androgen that's secreted by the adrenal cortex is called DHEA. In males, after puberty, the hormone testosterone is secreted in much larger quantities, so DHEA doesn't really have much of an effect. In females, DHEA and other adrenal androgens play a major role in promoting libido and are converted to estrogens. In menopausal women, all female estrogens come from the adrenal androgens. Let's look at the adrenal medulla for a second and those chromaffin cells. Remember I said sympathetic and parasympathetics earlier? So the adrenal medulla is going to push out the adrenaline and noradrenaline, or epinephrine and norepinephrine, which is the fight or flight response. So it's going to increase your heart rate, increase and dilate the pupils, open up the airways to relax the trachealis muscle so you can get more air in. It's going to increase your blood pressure to drive blood to your muscles so you can run and get out of danger's way. So let's look at how stress works and how stress kills people. Why does stress cause diabetes? Why does stress cause heart attacks? Why does stress cause strokes? Why does stress kill people? Let's take a look. When we look at stress, there's a short term and there's a more prolonged term. Now, this is really, really important because we have something called adrenal fatigue, which is happening a lot right now in the last year or so. When people are under stress, their adrenal glands get attacked really hard. All right, and let's understand why. Short-term effect of stress and the adrenal glands. Notice that one pathway sends signals from the hypothalamus to the pituitary and from the pituitary to the adrenal gland. That's the more long-term stress. The short-term stress has to be fast and rapid, right from the hypothalamus down to the spinal cord, right to the adrenal medulla. So the adrenal medulla is your short-term stress, fight or flight response. The long-term stress uses the hypothalamus pituitary adrenal axis. So when you go from the spinal cord to the adrenal medulla and you push out these catecholamines, the epinephrine and norepinephrine, the short-term stress response, you get increased heart rate, increased blood pressure, increased blood sugar, right? So now you have increased cholesterol. Short-term, this is not a problem. But you take this pathway from the hypothalamus to the pituitary to the adrenal cortex, and you push out the mineral corticoids and glucocorticoids. Now you have the retention of sodium and water by the kidneys. You have increased blood pressure. You have increased blood glucose. You have weakened immune system. You have this long-term stress kills. You got high blood pressure causing heart attacks and strokes. You have high blood sugar causing diabetes, which damages the brain and the neurons and the eyes and the kidneys. You got a suppressed immune system. You're getting sick all the time, especially at times of COVID. Stress does not help. We know that the risk factors are high blood sugar, people with cardiovascular issues, and metabolic issues. This is who's prone to this, right? So it's not that healthy people don't get it. Healthy people can get it. It's just you're not seeing healthy people take a turn for the worst. You're seeing people who are obese because of the fat cells releasing inflammatory cytokines. We're seeing people with kidney issues, with cardiovascular issues, high blood pressure, and metabolic issues like diabetes. Here's Cushing syndrome. This is a metabolic issue that involves the adrenal glands, where either endogenously or exogenously there's a high amount of cortisol. So you get this round moon-like face, you get this Dowager's hump in the back, this fat hump, you get these purple striae, which are looks like stretch marks of the skin, you get thin skin, you have high blood pressure, poor wound healing. This is really looks like this. This is what the purple striae look like. Here's the thin skin, the purple striae, the buffalo hump or the Dowager's hump here. Again, purple striae, the moon face. That's called Cushing syndrome. Okay, so remember the adrenal cortex pushes out the mineral corticoids and the glucocorticoids, whereas the adrenal medulla with the chromaffin cells push out the catecholamines, the epinephrine and norepinephrine. Now let's look at the pancreas. The pancreas is a mixed gland because it's endocrine and exocrine. Endocrine because of insulin and glucagon, exocrine because of the digestive enzymes that are released. So the digestive enzymes, believe it or not, most of the pancreas are acinar cells, right? These are exocrine in function. They produce these digestive enzymes to help you break down protein, fat, and carbs, because the body produces these pancreatic lipases, pancreatic carbohydrases, and pancreatic proteases. They break down fat, carbs, protein. Within the acinar cells are pancreatic islets. They're called islets of Langerhans. And there are alpha cells and beta cells of the islets of Langerhans. The beta cells produce insulin. Insulin lowers your blood sugar, whereas glucagon raises blood sugar. So you got these alpha cells and beta cells trying to regulate blood sugar. So here, if we look at the seesaw, now we have this imbalance. Well, let's look here. The imbalance where you have high blood sugar, you just drank a Pepsi or a Coke or something, and now the beta cells are going, hey, blood sugar is way too high, I got to push out insulin. And now insulin is going to say, hey, we got to get rid of this blood sugar, so let's store some. We're going to store it in the liver, and remember, anything that ends in -ogen is inactive. So it puts glucose in the liver, but the storage form of glucose is called glycogen. Glycogen is stored in the liver, and it's also stored in your muscles. It's the only two places the body can store glucose, in the liver and in muscles. Now you go from this high blood sugar back to normal. Now, if it dips too low, then the alpha cells of the pancreas go, hey, we need more blood sugar, so I'm going to push out glucagon. Glucagon is going to go to the liver where you had that stored glucose just waiting to be broken down back into glucose, and then glucose levels rise back to normal. When blood sugar is out of control, dietarily, we call it diabetes mellitus or diabetes mellitus. And diabetes mellitus, or diabetes type 2, right? Type 1 is autoimmune, where your body can't produce insulin. Here, this is more of a dietary and lifestyle-induced condition, which is one of the other risk factors, right? So polyuria, polydipsia, polyphagia, we call them the 3 Ps. So when you do a case history and someone says, oh, I'm peeing 15 times a day and I'm always drinking water, I'm drinking and I'm peeing, I'm drinking and I'm peeing, and I'm constantly hungry, those are the 3 Ps. Polyuria is increased urination, polydipsia is increased thirst, and polyphagia is excessive hunger. That is diabetes mellitus. The blood test for that, they call it the Hemoglobin A1c test. That's the biggie. Hemoglobin A1c. Not just looking at fasting glucose, but hemoglobin A1c. That looks at the amount of glycolated sugar that's hanging around your red blood cells. Glycolated sugar around your red blood cells over 120 days. Not just, 24 hours, but 120 days. Okay, we're getting close to the end. Reproductive organs, the testes and the ovaries, these are going to produce sex hormones. The ovaries will produce estrogen, either estradiol or estrone, along with progesterone, relaxin, and inhibin, and the testes produce testosterone. The pineal gland, which is just above the cerebellum, is going to produce melatonin. That's going to help regulate your body's biological clock. Don't confuse melatonin with melanin, right? Melanin is skin pigmentation. It's the pineal gland that's going to produce melatonin. Your thymus is located behind the sternum, and it produces thymic humoral factor and thymic factor and thymotropin. Those are going to promote the maturation of the immune system's T cells. So when we look at the pineal gland and the thymus, your thymus is right here. Here's your pituitary gland. Your pineal gland is in the posterior portion. I mentioned these eicosanoids before. These eicosanoids, the two biggies, are prostaglandins and leukotrienes. I brought these up again because the prostaglandins involve smooth muscle contraction of the uterus. It's also involved with blood clotting or platelet function. So when you use things like ibuprofen or NSAIDs for pain and inflammation, those are really prostaglandin blockers. So the contraction of the uterus decreases, but you can also thin out the blood and inhibit platelet function and thrombosis function. So when we look at the concept of pain and inflammation in your cells, in the cell membranes, right, that phospholipid bilayer, there is arachidonic acid there. And arachidonic acid is metabolized to produce these chemical mediators, prostaglandins and leukotrienes. And there are certain ways of inhibiting or blocking the conversion of arachidonic acid into those prostaglandins and into those leukotrienes. When you convert arachidonic into prostaglandins, you get pain, swelling, and inflammation. Well, if you take your aspirin or ibuprofen or those COX-2 inhibitors or COX-1 inhibitors, you'll never get prostaglandins. You'll get an ulcer, but you won't get pain, inflammation, and swelling. The leukotrienes, when you go this way, this is more like people that use these inhalers for asthma. These are more of your respiratory issues. So when someone has asthma and they take these LOX inhibitors and they block the leukotrienes, they don't get the inflammation around the airway or the bronchoconstriction or the airway obstruction. Now, you can use these chemicals and these pharmaceuticals to do it, or you could just as well say, how do I decrease the amount of arachidonic acid in my body? Just look at your diet, look at your foods. Many people are consuming a diet way high in arachidonic acid, and if you have lots of this precursor, you can have lots of prostaglandins and lots of leukotrienes. So do a little research and go, hey, what foods are high in arachidonic acid? Can I decrease those a little bit? Endocrine disorders, we spoke about goiter before, so on the top right, that's a goiter. Here is the Cushing's, that moon-looking face, the round face with the red cheeks, that's Cushing's. Here's your exophthalmos with the bulging eyes. You can see the white around the eyes. Here's an individual that has excessive growth hormone production as an adult. They call that acromegalia. When you get that thick androgenic type of like eyebrow and forehead that looks like the Neanderthal man, that's what we're talking about. When you have excessive growth hormone when you're a teenager, we call that giantism. When you have the increased growth hormone when you're an adult, we call it acromegalia. Okay, so we're going to bring this to a close. We'll see if anyone has any questions for me.